Deepak Padmanabhan, consultant electrophysiologist from Bangalore. This is one of my talks at the Excellence Academy for Pacing last year. This is a talk on syncope and the approach to the management, the role of loop recorders or external loop recorders for recording the rhythm, and how to manage syncope in the setting of various comorbid conditions. The definition of syncope essentially is one where you will have a global, transient loss of consciousness accompanied by loss of postural control with immediate reversion upon assuming a horizontal position. Why is it important? Because 40% experience syncope at least once in a lifetime. It is responsible for 6%, up to 6% of hospital admissions. 1% of emergency room visits every year are because of syncopal events. 10% of fall by elderly are due to syncope. It's a major morbidity reported in 6% of all traumatic events. And finally, it can cause minor injury in 30% of all cases of syncope. Syncope has various causes, and the focus of this talk will be more so on syncope due to cardiac reasons, mostly cardiac arrhythmias. So cardiac arrhythmias responsible for syncope can be sinus pauses because of either sinus arrest or exit block, high grade or acute complete AV block without an escape rhythm, and it can be associated by vasodilatation when you have reflex syncope or carotid sinus hyperactivity mediated syncopal events. Tachyarrhythmias like atrial fibrillation or flutter with a rapid ventricular rate across a bypass tract most commonly, or very rarely paroxysmal episodes of SVT can lead to syncope. Usually these have a history which is suggestive of some kind of palpitations before the syncopal event, and it can be useful to actually help discern what the reason for it is. Ventricular tachycardia and torsades are very rare events of syncope, causes of syncope, but if you go strictly by the definition, mostly these are events that don't really lead to syncope. As such, they lead to loss of consciousness or feelings of dizziness rather than syncopal events themselves. In patients with unexplained syncope, if you look at the various causes, there will be no recurrence of these episodes in 36% of cases. Bradycardic or tachycardic events are responsible for 22% of them. There can be a normal sinus rhythm during the event in about 31%, and there are other miscellaneous causes for the same. Mortality for syncope, especially in elderly patient, is greater than 10% at 6 months. Presence of cardiac cause for it doubles the risk of death, and therefore is the importance in understanding and finding out what is the cause of syncope. Because a cardiac cause could be a harbinger of sudden cardiac death. The challenges with syncope is that even if it's of a very non-life-threatening cause, the diagnosis is very complex. It has a lot of quality of life implications, especially when using heavy equipment at work, doing activities wherein other people's lives depend on you. And it also has a lot of psychological effects wherein the phenomenon of anticipation of an episode itself can impair the quality of life. Finally, because of the impressive list that is required to work up these patients, it is responsible for high utilization of healthcare facilities. The cost per diagnosis is very high, as is the cost of healthcare utilization every year. When dealing with a patient of syncope, it's critical that you have a diagnostic plan. There needs to be a method to the madness. As with all good clinical practice, an initial history remains a critical component. A physical examination that is detailed, including examination of peripheral pulses, looking for deficits between the cardiac beats as well as the cardiac beats felt in the periphery or called as apex pulse deficit, blood pressure evaluation, especially in at least two positions, with a rest of 3 minutes between the measurement of blood pressure, and a good 12 lead ECG are critical initial examination points. If all of this and including an echo do not reveal anything contributory, monitoring these patients for evaluation of cardiac rhythm during an event or inducing an event by doing tilt table testing is of value. A Holter and event monitor are usually ways of monitoring patients if these events are frequent or even once every week. If the events are much more rarer, then or they don't have a particular pattern, an insertable loop recorder, an ILR, is of value. Cardiac imaging to rule out any causes of cardiomyopathy is useful but not very specific or not very sensitive. Special investigations like doing an EP study with the understanding that we may have to give medicines to evaluate the underlying conduction system, performance of hemodynamic studies, or performing the head-up tilt testing in an outpatient department is of great value. Of late, the role of ambulatory blood pressure monitoring has also gained traction. The study that we are talking about evaluated a 24-hour BP monitoring profile associated with patients who were diagnosed with reflex syncope. It showed on an average a lower 24-hour systolic blood pressure, a higher 24-hour diastolic blood pressure, a lower 24-hour pulse pressure consequently, and more frequent daytime systolic drops less than 90 millimeters of mercury. The 24-hour pulse pressure less than 32 millimeters of mercury had the highest predictive ability for reflex syncope with 80% sensitivity and 86% specificity. This is a very useful test, especially in patients who have hypertension as their coexisting morbidity, and it confirms the presence of a hypotensive hemodynamic profile in reflex syncope, which is expressed here as low systolic blood pressure and tendency for daytime BP drops. This, therefore, is a very useful test that is coming up the ranks in evaluating patients with syncope. What is also important is the ability to understand what drugs the patient is on, especially for treatment of hypertension. And when you review them, there are certain drugs which are at low risk for causing syncope, whereas there are some other drugs, especially the alpha blockers and the central alpha agonists, which may be at very high risk of causing syncope. So therefore, if you have a patient of hypertension on medications, one may want to switch from a drug at a higher risk of causing syncope to one that has a low risk of causing syncope. In general, syncope, as I mentioned, is a transient loss of consciousness. If you suspect the episode is a syncopal episode, the initial evaluation with history, physical examination, and ECG is a class 1 indication. Out of this evaluation, one gets a direction which one can then use to ascertain what tests are to be prescribed next. Serious medical conditions, if they are present, an inpatient evaluation is a class 1 indication, whereas an outpatient setting is useful for presumptive reflex mediated syncope suspicions. Structured emergency department observation protocol for intermediate risk patients is also useful, but we still don't know how to manage cardiac patients in an outpatient setting. The diagnostic evaluation for these episodes have to be considering the possibilities of reflex or orthostatic intolerance, cardiac causes, and most importantly, the unexplained and high risk for possible sudden cardiac arrest, and therefore understanding of and ruling out possibilities of genetic cardiomyopathy or inherited channelopathy. The clinical presentation of epilepsy and syncope can be confusingly similar, and as such, we need to ensure that a neurological opinion is also sought. As mentioned above, there are various continuous monitoring devices that are available, and depending on whether the episodes are daily, present within 7 to 14 days or are infrequent, appropriate monitors can be used. In terms of diagnostic efficacy, the ILR has the maximum, wherein the yield is approximately between 43 to 88%, and it takes about 14 months for the ILR on an average to give us value. This does not mean that an ILR would not give value if the episodes are more frequent, but it only means that the ILR is cost effective when you have used it for the right indications. When you have an ILR or a loop recorder indicated, then the ILR actually helps you with documenting what the underlying rhythm could be during that episode, and as such is very competitive when you have a rarer cause of the event. When the ILR is used after having done all the tests prior to implanting the ILR, including a Holter and external loop recorder, the ILR actually causes change in management, wherein it rules out most commonly an arrhythmic cause in most patients, and it can be used to prescribe a pacemaker in a large number of them. Triggering off either the antiarrhythmic drug or the pacemaker or anticoagulation are important interventions that the ILR can spearhead. Again, if you look at the impact of the loop recorder, not too many people required continued ILR monitoring beyond 18 months. 12 to 14 months remains the sweet spot for ILR. This is especially true when you consider patients with syncope requiring continued ILR monitoring, whereas if you have patients with palpitations, it usually goes on up to 18 months, after which it steeply falls. It's very rare for patients to be undiagnosed at 36 months and still require ILR monitoring. Patients with cryptogenic stroke are very important, where an ILR actually is able to give you a decision within about 12 months of implantation. The loop recorder itself can improve outcomes even in the subgroups of patients presenting with syncope vis-a-vis palpitations in being able to tell us what is the value of implanting the ILR. In our study, we were able to show that overall you needed approximately 2.4 ILR implantations for cardiac change in management for the patient, whereas for an invasive intervention, nearly 8 ILRs had to be implanted. If for any change in treatment, an ILR had to be implanted, even 2 ILRs implantation can aid in change in treatment. This is mainly driven by the syncope and palpitations group, whereas in cryptogenic stroke, you needed at least 4 to 5 ILRs to be implanted for one patient of atrial fibrillation be diagnosed. Now, also had this study where we had patients with syncope who did have bifascicular block, and you're confused whether these patients should be implanted with an ILR or should be given a pacemaker directly. These patients over the age of 50, when randomized to an ILR versus a pacemaker, evaluating for a composite outcome of syncope, bradycardia, device complications, and cardiovascular death, showed that patients who were implanted with the pacemaker had a lower cumulative incidence of the composite outcome as compared to patients who were monitored with an ILR. As far as syncope is considered, there is no difference between the monitoring group and the pacemaker group, suggesting that there may be more than just conduction system abnormality driven episodes or mechanisms of syncope, but given that the composite outcome of bradycardia, device complications, or cardiovascular death were significantly lesser in the pacemaker group, perhaps in this group of patients, close to around 70 years, a bifascicular block with presentation of syncope may be of pragmatic value to implant the pacemaker directly. Of importance, the pacemaker implantation primarily reduces the procedures at no cost to the outcome rate. All patients either exited or crossed over to the pacemaker from the intracardiac monitor arm. If you look at the various diagnoses that we've made, we note that the timing of outcomes in the intracardiac monitor arm was within the first year, mostly around here, where both, even if they were asymptomatic or presented with pre-syncope or syncope, within about 1 month, we were able to figure out what is the probability of the abnormal outcome. Now, in the presence of or absence of structural heart disease, if you had syncope and bifascicular disease, and perhaps an electrophysiological study was considered, one noted that there was independent value to implanting the pacemaker rather than allowing an electrophysiology study guided intervention. You can see the independent groups, that's group A, group B1 and B2. The electrophysiological study did not add significantly any value over and above the presence of either LBBB or diabetes mellitus to the implantation of the pacemaker. Now, when looking at Brugada syndrome and syncope, in patients with suspected Brugada syndrome, the presence of the loop recorder was able to find arrhythmic events in only 25% of patients out of a value of 370 patients. 74% of patients in this group were symptomatic, and this was over 3 years of follow-up. Arrhythmic syncope was present even in patients of Brugada syndrome in only 8.6% of patients, where also it was the bradyarrhythmia close to 60% which was responsible for the syncope. This again suggests that even though conduction system abnormalities may be present in both patients in elderly group as well as in patients with Brugada, when these patients present with syncope, reflex syncope remains an important differential to evaluate and treat for. One can also have more than one reason for syncope in a given patient. When again evaluating these patients, one showed that there was a reasonably high recurrence of syncope in patients with Brugada, and it was mainly the reflex syncope arm that was responsible. When you do a negative electrophysiological study in a patient with Brugada and then implant an ILR in those patients who are negative, again, adverse events were present in only 28% of these patients, whereas therapeutic intervention was seen in about 61% of these patients. Bradyarrhythmia still remain the most common events in these patients at 39 months median follow-up. These patients actually presented nearly 70% with unexplained syncope, with only 17% who were presenting with palpitations and 17% who were asymptomatic. So recommendations for long-term ECG monitoring are mainly patients with unexplained recurrent syncope or pre-syncope, mainly valuable in patients with post-MI patients and LV dysfunction, or in patients having neurological events or unexplained recurrent palpitation, or in patients with persistent symptoms, to evaluate also for antiarrhythmic drug response in patients. The implantable cardiac monitor is a very small device which can be implanted by just a small incision in the precordial region and consists of an injectable recorder which can be done in the outpatient department itself. The transmission is mainly via Bluetooth, allowing both the patient as well as the clinicians to understand when the patient has had an episode. Cardiac syncope includes cardiac arrhythmias and structural heart disease. It's often life-threatening. It may be a warning of critical cardiovascular disease, and it is important to assess the culprit arrhythmia or structural abnormality aggressively. From the general population to medical settings, the referral to the emergency department is just 0.7, suggesting that there is a high burden of disease that doesn't get managed or referred or evaluated very well. Neurally mediated syncope can either be because of reflexes like the vasovagal reflex syncope or the carotid sinus hypersensitivity or post-exercise, or it could be because of orthostasis, wherein there could be both primary and secondary autonomic failure or volume depletion. The mechanism is mainly via the Berthold-Jarisch reflex, wherein the trigger causes a decrease in venous return, decreasing blood pressure, which in turn increases the sympathetic tone as a response to it, which causes increased inotropy and contractility, leading to wall stretch, activation of the C fibers, thereby causing increased vagal activity, leading to syncope. The history and physical examination without any further evaluation is sufficient when we have a young patient having the first presentation or clear situational dependency on posture. There is a normal physical examination, normal ECG, there has been no injury, and the patient is in a low risk occupation. These patients do not need to be evaluated further and can be managed conservatively. The rest of them definitely need a history and physical examination, ECG, a tilt table test, an echocardiogram, an EP study if indicated, a Holter monitor to record events or a loop monitor to record events over a longer period of time, neurological consults, psychiatric evaluation if required. But the three major ones are as highlighted above. Strongly to consider echocardiogram when there is suspicion for hypertrophic cardiomyopathy. The stratification for an EP study is mainly when the ejection fraction is 40% or below, and we want to induce for ventricular arrhythmias. The tilt table test is done in an outpatient setting. It's a valuable test and has great importance in the armamentarium. A positive test rules in vasovagal or reflex syncope, whereas a negative test has got poor specificity for ruling out these conditions. Currently, a new protocol, namely the fast Italian protocol, has been used to further decrease the duration of the test, wherein we perform the traditional HUT by using a protocol called the fast HUT, where there is a 5-minute supine phase, a 10-minute tilt passive phase, and a 10-minute nitroglycerine phase, compared to a 20-minute and 15-minute stage 2 and stage 3 respectively. When randomizing 554 patients with a predominance of males at around 45 years of age to one of these protocols, the positive rates were much higher for patients who had the fast HUT protocol as compared to patients who were with the traditional protocol. The tilt testing positivity rate goes down as the emotional triggers, situational triggers are lesser. It is less likely to be positive in patients with cardiac syncope and tachycardic syncope, but it is not always negative. An electrophysiological study is used to risk stratify for ventricular arrhythmias, but it is poor at diagnosing bradycardic arrhythmias. It has a negative predictive value of only 0.5 and is highly sensitive for tachycardias, not bradycardic reasons for syncope. The red flags for patients in syncope include syncope resulting in injury during exercise, in the supine position, with known case of structural heart disease, or with any of the following ECG abnormalities. If there is a family history of sudden cardiac arrest or death, it is a very important red flag which should prompt or trigger a very intensive workup for this patient. Also, if syncopal episodes are greater than 2 per year, it is important we evaluate what the cause is with further monitoring. Any patient having either an implanted pacemaker or defibrillator undergoing syncopal events has to be evaluated with a monitor to find out if there is a cardiac rhythm abnormality during these episodes. Additionally, patients having high risk occupations like being a bus driver or a pilot also have social responsibilities, and hence syncope in these patients should prompt an immediate intensive workup. Advanced age, however, remains the biggest red flag to undergo a thorough testing for patients of syncope. Reflex syncope is usually a disease of the young. Syncopal episodes in advanced age should prompt the search for a structural cause to explain these events. As Dr. Furman used to say, the longevity of a pulse generator is substantially under the control of the physician who programs or doesn't program. All this depends on the programming action taken by the physician. Similarly, us evaluating patients and classifying them into low risk or high risk based upon physical examination, past medical history, and ECG and echo is of very great importance in evaluating these patients. One important testing is the testing for neuropathy or amyloid, which is often missed and can lead to progression of the disease from a stage where it could have been treated to a stage where it is challenging to be treated. In patients with suspected reflex syncope, fluid intake, use of midodrine, ivabradine, or fludrocortisone may have value. It's important to realize that these patients have to avoid driving for at least 3 months post syncopal episodes. They should not be locking doors once the event has come in, so that people can actually access them if they have an event. Exposure to fire by standing over it or while cooking is extremely dangerous, and this has to be carried out till they have a syncopal event-free period of at least 3 months. In summary, therefore, syncope remains the abrupt transient loss of consciousness with inability to maintain postural tone and rapid spontaneous recovery. It may or may not be associated with prodromes. It may have mimickers like epilepsy, cataplexy, psychogenic syncope, or metabolic disorders. You have to rule out an encephalopathy. The syncopal syndromes are either the WPW, the HOCM, the Brugada, the ARBC, or abnormal electrolytes. Trifascicular block or bifascicular block with syncope are a worrisome subgenre for diagnosis. The QT intervals have to be known in all these patients and classified into whether they are normal or abnormal. Family history is an important predictor. Pulmonary embolism ECG features have to be noted, and the presence of Osborn waves and fascicular blocks have to be evaluated. Severe, unpredictable, recurrent vasovagal syncope, once you have documented a cardioinhibitory mechanism, needs to either be evaluated and managed using a pacemaker if the age is greater than 60, or you might want to perform cardio-neuroablation if the age is less than 40. But it's important to realize that conservative measures often do well, and cardio-neuroablation remains under evaluation and investigation for long-term data. In summary, therefore, diagnosis of the cause or mechanism of syncope is challenging. History is the key. Prevention of injury in these patients remains a primary goal. We have a large testing arsenal, and it has to be used judiciously to prevent over-investigation of patients. An ILR is useful to document the rhythm at the time of an event, and for most cases is required to be present in the body for 12 to 14 months. Pacing in a pre-existing bifascicular block is useful, especially in the elderly. Tilt table testing is useful to document with high specificity for reflex syncope, although arrhythmic causes may also present with positive tests. Autonomic testing is also useful to diagnose conditions like primary autonomic failures or amyloidosis. An EP study may be useful for tachyarrhythmias but does not do very well in patients with bradyarrhythmias. Thank you for your patient listening.